the person right there, we start with the CPR. So mi nimekuja, patient wangu amecollapse, I've assessed, no pulse, no breathing. I immediately start with the CPR. Sawa. So I'll show you the technique and then we'll do a return demo. So basically to locate the landmarks at the sternum, the lower third, we use the heel of our palm, we lock. You ensure you are comfortable. Naona the way I am, I'm not comfortable. I cannot do it well. Luckily, I have a stool. So mona this angle, 90 degrees. We use the heel. I lock the lower third of the sternum. And ensure you don't bend your elbows. Afu tena si dance. You lock, you apply the heel. 1, 2, 3, 4. Kwa the algorithm, they have written up high quality CPR. There are those 4 things to consider. Sawa. We ensure at least 100 to 120. Sawa. Yes. So the pace yenye tunaenda. Sawa. And also the anteroposterior diameter, at least 5 to 6 centimeters. Because the anteroposterior diameter, let's say it's about 9. So at least 2/3 in. That is 5 to 6. And we ensure chest recoil. Tusifanye tu. We want refill of blood and then the blood goes. And as you've called, because when you've noticed the patient has collapsed, you immediately start the CPR. Nobody is there to help you, but you've called for help because you can do the rest of the chest compression alone. So as the other team members come, they will assist you. So another one will go to the airway. Another one will fix the patient monitor or the defib. Another one will fix the IV line. Another one will take the sample. So it is teamwork. You cannot do it alone. So with the CPR, we do 30 chest compressions, 2. Sawa. Yes. Swali yoyote?
On the 4 parameters, we also minimize interruptions.
Yeah. We minimize because vile tumesema, so you've called for help, you start the CPR. As the other team members are taking over, hapo ndio they relieve you. Sawa. And then early administration, because we will put the patient on patient monitor, you can also use the defib. How the monitor tells us the rhythm, the interventions come about and we do the interventions. Sawa. And
quality CPR, also avoid excessive ventilation.
yes.
Just give enough to optimize our chest strength, and then if the patient is intubated, we just give 1 breath at every 6
So, yes. So I did the ampu bag. So when ventilating our patient, because it's 32, we don't do that the whole thing. Sawa. just enough to get a chest rise, like this, not the whole bag. So, just enough to get a chest rise. Sasa, we don't want, sasa hivi tunaona tunasaidia huyu mgonjwa sana. So, just enough. So, at least, and when you are applying the ampubag, at least 1 second. 1 second. So, yeah.
So you have said you are getting 5 compressions against 2.
Yes.
Two plants.
Rescue breaths.
2 rescue breaths.
Yes.
Okay, maybe for, sometimes you were 15 against 5, so maybe that's 30 against 2.
Maybe.
There's a time we were getting 15 against 5. No, against 2.
Against 2.
Yeah.
Hiyo ni ya kitambo. And it is 3.
It's not even a mandatory for kids, because there is also 30 to 2 in pediatrics.
That one is neonate. 3.
2 rescue.
2 rescues.
You do 15 to 2. Then 1 rescue, that is 30.
For neonate is 3, 1, 3, yeah.
Also, I'm seeing maybe some consultants in the facility, when the patient comes and maybe the patient is gasping and there's no sign of life, we allow an anemia. You can do the patient. Is it allowed? Stimulation.
You see, when a patient comes, maybe that's the way they check for response. But you can just tap the patient, Mr. Wafula, to check for response.
I think what is referring to, in most cases when a patient is unconscious, you always want to know the GCS.
Yes.
So for standard pain infliction under the GCS assessment, you do sternal rub. Sternal rub will elicit the amount of pain that you need to give you proper GCS assessment.
Yes.
So when you see consultants do that, they want to assess the level of consciousness of the patient in relation to the GCS.
Yes.
So let me just say, when you say patient was gasping or having a problem breath, that's just a sign of cardiac arrest. So don't waste time doing your just start your CPR. Right?
Exactly. We're not doing GCS assessment of people who are not breathing.
Yes.
Just start your CPR, just for pressure. Don't waste time doing this.
Yeah, that one is post-cardiac arrest. Yes. Sasa.
Thank you.
Any questions as we move by?
For effective and efficient CPR, how many people are you supposed to have?
Actually, 3 is ideal.
3 is ideal.
1 doing the compressions and actually 2 working the airway. So your most experienced provider should be holding the BBM while the other person's just breathing and the other person's doing compressions. All you're doing, that's the ideal way. And it's 30 to 2 for adult, infant, and children. If you are intubated, then it's 1 every 6 seconds. So you don't have to do the 30 and 2. You still do the 30 compressions, but every 6 seconds you intubate.
So.
Who's stopping the CPR?
When are we stopping? We are not stopping, we are continuing. But until we get a pulse, because what I can say, it depends on the patient. It's individual. I cannot say that after 30 seconds, 30 minutes we are calling it off, or that. It depends on your patient, how the patient has responded, how the patient is responding, like that.
Can we say even after the return of the pulse?
Even that, when there is pulse, you cannot continue. There are other measures that we do. Yeah. There are several, but it all depends on how the patient responds. So
let me try. Sorry?
I was also trying to respond to a question when to stop the CPR1. If you're a BLS service provider, you can stop your CPR once the SLS service provider has arrived on the scene. That is 1, 2.
if your victim or your patient has achieved the ROSC, you can also stop your CPR, and then now you optimize your post-cardiac arrest management. Then other things now she can respond.
Very correct. So 1, when your patient achieves ROSC. 2, and legally, when you're allowed to stop, when you have gone, I hope we all have the casualty app by now. So when you check that algorithm of resuscitation, it's when you've gone through the full cycle, you've assessed for your H's and T's, your reversible causes, you've attempted to reverse all of them, and your patient is still not responding. That is when you are legally allowed to stop. So in your management, in your documentation, you have to show that you checked for each one of them and you intervened and the patient still did not respond. So whether that takes 20 minutes or 1 hour, you have to go through the whole algorithm. I hope you are clear on that.
Yes.
Legally. So yes, when patient gets ROSC, when you've gone through the whole algorithm, okay, if you're by yourself, let's say in an out-of-hospital setting, and you find you're by yourself, if you're completely tired and completely worn out, yes, you're allowed. But you have to show that you did the work, even in your documentation. When it is not safe, I hope you're not, in a building with fire or somewhere where it is not safe, okay? Then there sometimes you don't even start. But we are trying to work in the context of a hospital setting where you have at least most of the resources. The only time you stop is you go through the full algorithm. And your patient still does not respond. So that may require you, we'll talk about pediatrics. In pediatrics, you have to go much longer. There are scenarios where you prolong CPR.
Is this protocol or what this for every hospital in Kenya, or just one?
So these are the ACLS protocols.
Right, but I mean, is every hospital, as American, is
Yes.
every hospital in Kenya, if I'm in Lamu or if I'm in Naivasha, they're all gonna follow that same protocol that you just explained?
That
Yes.
is what we are trying to get
Okay.
with our
But that's
training
not
session.
necessarily the case.
No, practically it's not the case, but that's where we want to get to, that everyone has these algorithms in every station and they're able to follow them.
Just for us, we have to make sure they're warm, so they have to be, body temperature has to be normal temperature.
Yes.
And we in the US have to do now bilateral chest decompressions before they can call it. Because we don't know, it's not really in the H's and T's, but now we're starting to see that, so we do bilateral chest decompressions, be warm, and then go through all what she said, and then the doctor, in some states, paramedics can call it, but most places, the physician.
But I think I want to say in Kenya, all the healthcare workers are trained on how to resuscitate. The unfortunate bit is that most of us don't practice. So that's why there's continuous trainings and doing of the BLS and SCLS training.
So you are shift working, then you are called, there's a patient who has been totally responsive. What do you do?
First of all, you confirm the patient and confirm if there's pulse. She told us, maybe you can feel the
So we said before you check your pulse, you need to
stimulate
or responsiveness.
responsiveness.
So your patient is not responding.
Not yet, not so we can
So this patient should maybe need to begin a resuscitation. First of all, before we begin the resuscitation, you have to feel his pulse. You feel the pulse, maybe using your fingers here.
So how long are you checking for the pulse?
Maybe around 1 minute.
Less than 10
10
seconds.
seconds.
There's no pulse.
So now, there's no pulse. We don't plan and we begin the station. We have here in a monitor or vent. So maybe you are a team. Another one will fix IV line.
Let's do it. Let's do it. So there's no pass. You're the one who has attended. There's no pass. What do you do?
So, first of all, I fix IV line.
You call for help.
Yeah, I shout for
Remember,
help.
you cannot do it alone.
I shout for help. From there, another thing, as I've said, it's help by maybe putting lines.
There's no pass. So there's no pass.
There is
You
no
call for
pulse.
help. Where? What do you do next?
First of all, the oxygen.
Start CPR.
No pulse, CPR.
Fine.
So as you're saying, you take your fingers and fold it there, and you should get around 120. That means
100 to 120
100 to
at a rate.
And you make sure your shoulders they are straight.
At the sternum. Hapo.
Kwa hivyo now.
You should also be shouting the
Deeper.
Oh, deeper, deeper.
Yes, and fast.
Oh, unakuja mkono.
Usikunje.
Wewe trick unakuja hapo.
Haya. So faster rate. And then ensure recoil.
Oh, so recoil.
Yes. That
4, 5, 6, 7, 8, 9, 10, 11, 12, 13.
like this, and then you do a C and E. Try bag.
C and E grip.
Yes.
Don't talk to your patient, otherwise. Lift the
I
chin.
love lift up. Yes.
Not rising.
Be able to see
The chest rise.
rise.
Yeah. But our mannequin is not for. Yeah. CPR. Minimum interruptions. Equal straight. Yeah, alafu unaweka ugali hapo. Harder.
Press deep now.
Yes. Go with that bit. Faster.
That's not effective. Like that.
Yes. With that bit. Tap, tap, tap. And then you go deeper. Mpaka usweat.
Sasa mwili yote inasonga. Mwili yote inasonga.
Oh, hii mikono ya technique.
Just be steady. Just be steady.
You use your shoulders.
We can change.
Yes, another team.
Another team.
Yes.